All right, so we're going to get started. Very special welcome to everybody who's tuning in for yet another EBFA webinar. We've been going strong on these Thursday webinars on a monthly basis for almost 2 years. So I'm very excited by all the support that everybody is providing. If this happens to be your first webinar that you're tuning in on, very special welcome. And if you are a return attendee, then of course, very special welcome to you as well. So tonight's webinar is based off of a lecture presentation that I did on behalf of Triarch in September. And it was based around kind of getting back into the season for young athletes, kind of back to school theme, and wanted to carry it on and share it with those who may not be Triarch members or may not be familiar with Triarch, and of course share it with the EBFA family and community. So the way that we're going to do it is going to run through the webinar and again, hopefully present some new and exciting ideas for everybody who happens to work with young athletes, patients, or clients with any ankle issues. And then we'll do some Q&A at the end. There's an area where you can type in your questions and we'll go through that at the end. So all of the webinars are recorded and archived and can be found on the EBFA YouTube page, which is youtube.com/EBFA Fitness. So we will get started. So again, we're doing prevention and treatment of ankle ligament injuries in the young athlete. Because EBFA is very much focused on barefoot science and from the ground up rehab programming, this is going to be focused again on a lot of the neuromuscular training that we're doing with our clients, patients, or athletes versus looking at kind of that surgical perspective. But if you do have an athlete or patient who does have the surgery, whether they have surgery or they're opting to not have surgery, they end up getting to the same point, which happens to be doing some sort of neuromuscular rehab. From an importance of the topic perspective is that we know that a huge percentage of our injuries are happening to the ankle. In fact, 60% of basketball injuries occur in the lower extremity, which makes sense when we start exploring when or what point of gait or takeoff that we're actually seeing ankle injuries. It will make sense in basketball. 75% of ankle-related injuries are, of course, ankle sprains. It makes sense. We know that a great majority of these are actually inversion related. So we have almost 85% of ankle sprains are actually inversion ankle sprains. What's interesting is that 70% of ankle sprains typically have recurrent symptoms. And this is regardless of their grade. So whether they actually have a partial tear, a full thickness tear, 70% of these ankle sprains are getting recurrent symptoms, which means that us as practitioners need to look at the neuromuscular rehab that we're doing with these athletes or these patients. And it's interesting is that a history of an ankle sprain, even one, leaves an athlete at a 5 times increased risk of re-injury. And most of the patients who I see as adults who now have a severe ankle injury, and I'm seeing them in their 30s or 40s, I ask them if they've ever played a sport and have ever injured their ankle when they were, say, a teenager playing a sport. And an overwhelming majority of them have. So not only do we need to look at what sort of rehab are we doing, but we actually need to look at how we can prevent that first ankle sprain from ever happening in these young athletes, because that's where we're going to prevent future ankle sprains into their adulthood. And that's something that I'm very passionate about, that area as well. So some of the sequelae that we're looking at, if we do have an athlete or patient with a history of an ankle sprain, obviously they can start getting what's called chronic ankle instability. We're going to look at the different types of chronic ankle instability, where we know that we have something that's a little bit mechanical, and then we have something that would fall under more of a functional ankle instability. We can also see, or kind of the sequelae to that ankle sprain could be what's called a chronic regional pain syndrome, or a chronic pain that's the result of tension on a nerve. So they're getting chronic pain. And again, this is one of the saddest things that you see is you get a young athlete, late teens, they sprain their ankle. They happen to sprain it to the certain degree that they put enough tension onto those lateral nerves, and now they're experiencing chronic pain and have to be on pain medications and a lot of those Lyricas and gabapentins, and it's sad because it really changes their career. So obviously a sequelae to an ankle sprain is that you can end an early athletic career. So some of the anatomy, just so we're all on the same page, is we have ATFL, CFL, PTFL on the lateral side of the ankle. On the medial side, we have our deltoid ligament. Deltoid ligament has both a superficial and a deep part. It's much stronger, it's much broader. We have more inversion than eversion, which is typically why you see more inversion ankle sprains. And then the damage that is done to the lateral ankle is usually greater because the ligaments are smaller. We have an anterior posterior tib fib ligament. So if you ever see somebody or you've ever heard of a high ankle sprain, it's actually that tib fib ligament that they're either spraining, partially tearing, or doing a full thickness tear. That would be your high ankle sprain. We have our peroneal tendons on the lateral side of our ankle, so they're going posterior to that malleolus. And then we have retinaculum, which if you've never or you haven't looked at kind of the fascial anatomy of the foot and the ankle, is that we have retinaculum that run along the anterior and the lateral side and the medial side of the ankle. And what it does is it really prevents those tendons from bowstringing, and it also has a little bit of proprioceptive role in stabilizing the ankle. These retinaculums are direct extension of your fascia. So if you're big into fascia, you would want to explore a little bit on the retinaculum and the role that retinaculum play in proprioception. So how do we maintain lateral ankle stability? Right? So we just went through the mechanical ways that we maintain ankle stability. What's important to understand is that we both have that mechanical, but then we have this huge component of neuromuscular control. Having mechanical stability is not enough. You still must have sufficient neuromuscular control, which means that if you have an athlete who tears a ligament or they tear their peroneal tendon, that means they have now disrupted their mechanical stability. You go do surgery, you repair the tendon, you repair the ligaments, you build that mechanical stability back up. Does not mean that they will re-injure their ankle, because mechanical is not enough. We still must train the neuromuscular control. When we say neuromuscular control, this is where we're talking about proprioception. So that kind of keyword proprioception, we're going to explore it a little bit more on where these proprioceptors can be found. And then a huge part is that neuromuscular control of your ankle is highly dependent on the co-activation of your hip. So our rehab has to be training the foot and the hip to speak to each other a little bit faster. And then perhaps we can start preventing some of these ankle injuries. So, causes of ankle injury. What point of gait or foot contact or takeoff are these ankle injuries happening? If we understand when they're happening, we can obviously build programming to prevent that injury from happening at that point. So we are seeing that ankle injuries happen during initial foot contact and during terminal unloading, right? So it's during foot contact and takeoff or push off. If you understand kind of triplanar motion of the foot, you'll know that during foot contact and terminal unloading, your subtalar joint is in an inverted position, right? So it would make sense that if you're in an inverted position during these 2 points, that would be your point of highest risk of an inversion ankle sprain. We do not see ankle injuries when your ankle is fully loaded. So that means you're in mid stance, right? Or you're in a single leg stance position. It's when you're transitioning into or out of that single leg stance position. We typically see an impaired proprioceptive control at foot contact, right? But again, we want to think about what's happening during initial contact, and can you get the control to be a little bit faster during initial contact? And then when you're taking off, can you get that foot and that hip to again speak to each other a little bit faster? So if we look at the grades of ankle sprain, And again, just real quick, we're not going to go too much into the more severe grades of ankle sprain, but grade 1, nothing's torn. You got a little micro irritation, right? This would be your typical or majority of your ankle sprains. Most grade 1 ankle sprains never go to a doctor. They kind of walk it off. Maybe they limp for a couple days, do an ACE bandage. The coach tells them to take a day off, and then they're back into playing. Grade 2, you actually would see a partial tear. And then a grade 3, you would start to see a full thickness tear, specifically in that ATFL. If we look at the anatomy, your ATFL is the closest to the anterior, and it is stressed when you do plantar flexion and inversion. Your CFL, which is in line with the fibula and the calcaneus, that is stressed when you do inversion and dorsiflexion. But you cannot rupture or tear your CFL without first tearing your ATFL. So as far as you're like gauging the severity of an ankle injury, if an athlete or a patient says that they have a torn CFL, you better assume that that ATFL is torn as well, and then that would obviously progress the severity of that ankle injury. Whether they're grade 1, grade 2, grade 3, they have surgery, they end up doing just rehab, their neuromuscular programming still should be the same. And we're going to go into that. A lot of these grade 3 tears, actually don't rush to do surgery on them. We let them scar down and then build neuromuscular control on those scarred ligaments. So, treatment, again, for any of the coaches or rehab specialists out there, podiatrists, right? We know that early mobilization is kind of the gold standard, right? You don't want to put that patient or that athlete in a brace on crutches and totally locked off of that foot for a prolonged period. We know that we need to get those nerves firing as quickly as possible, and that's what's going to protect that athlete or that patient. Physical therapy, again, I send every patient to physical therapy, whether they're a grade 1, grade 2, grade 3. Patients who have grade 1 and don't want to go to physical therapy, I'm giving them the physical therapy to do at home, but they still have to do something about neuromuscular retraining. Even the most minor ankle sprains have a disruption in their proprioceptive response. So, sent the patient, they come back 6 months later, they're still getting this giving away sensation, right? What are we going to do? Do they have a mechanical instability that maybe we missed, right? Maybe they have a tear that has not scarred down and they have a little bit of laxity in that talus. Okay, we can do a little Taylor test, anterior drawer test, a Taylor tilt test, see if they have some sort of mechanical instability. Maybe they have a tear in the peroneal tendon, right? And then we know that we need to fix those mechanical instabilities. If we rule out all of the mechanical instabilities, we look at the functional instability now. This is a deficit in their neuromuscular control, and that is the role, and that's going to be the focus of this webinar, is how can we change our neuromuscular programming to better benefit these patients or athletes with functional ankle instability. So if we think about our current rehab protocol, right? Anyone who works with athletes or patients who have a history of ankle injuries, we typically like to put them on unstable surfaces. We typically like to strengthen their peroneals. And we're specifically looking at the peroneal reaction time, right? Maybe we'll put them on a wobble board, maybe get them on a little Bosu or Eric's pad, and maybe you implement some sort of taping or bracing, especially for athletes. Right? What you're doing when you're doing these peroneal reaction times, these unstable surfaces, is you're training what's called you're training the reactive or the closed-looped neuromuscular response system. Reactive neuromuscular training is based off of sensory input that then goes into the central nervous system. Your central nervous system processes it, brings a signal back down to the motor unit, and then it pulls the peroneal into a concentric contraction, and your foot is out of that inversion, right? So we usually think of reactive neuromuscular control as you're walking, you're stepping off of a curb, you get this stretch sensation, goes into your central nervous system, goes back down, contracts, and pulls you into eversion, right? That would be your classic peroneal reaction time. What we see and what all of the research shows, and it's actually really interesting, is that training peroneal reaction time is actually not fast enough. right? So this first study, this 2007 study, showed that that stimulation of the perineal reaction time actually didn't even go up into the central nervous system until you were completely done with the inversion moment of that subtalar joint. That means that there's no way that that response can protect that athlete from injuring their ankle. These other two studies have shown that we have delays. You have a delay in the perineal reaction response, 54 milliseconds, 63 milliseconds, right? It only takes 80 milliseconds to sprain your ankle. So if we're training our athletes and our patients just for reactive neuromuscular response, perhaps that's why we're still seeing injuries or re-injuries among these patients and these athletes, because we're training a motor response that is not fast enough. Okay, if we look at bracing, and we're going to see maybe what's a little bit faster than training reactive neuromuscular response. If we look at ankle bracing, right? I do some taping for athletes, and when they're doing their ankle rehab, a lot of the research is actually kind of controversial. Some people say that bracing and taping is better. It improves performance. Some say that it actually kind of limits your range of motion. So there's a lot of conflicting research on ankle bracing and ankle taping. I take the perspective of getting them out of anything that's an artificial environment and building that neuromuscular and that proprioceptive response kind of innately or from the ground up. So if you do bracing and you see that you get good results, that's fine, right? That's totally fine because some of the research does support that. But what we want to do is challenge what else we're doing, and that's what's going to lead us into rethinking what we're doing as our proprioceptive training. And this is where we're going to look at 3 areas that maybe we could just kind of add in or spice up some of our programming for our athletes and our patients. We're going to look at the difference between preactive and reactive neuromuscular training. We're going to look at the difference between small nerve training and large nerve training. And then we're going to look at the difference between coactivation or training coactivation patterns compared to training isolated foot and ankle or perineal strengthening. So we went into reactive neuromuscular control. That's your closed looped. And now we're going to look at what's called your preactive or your open loop neuromuscular response. This is what your neuromuscular system is doing before your foot even touches the ground. When we walk, your nervous system is so intelligent that what it can do is it will remember the previous steps that you just took. It'll remember the surface that you walked on, the amount of ground reaction forces, the degree of stability that you required in your subtalar joint and in your ankle. And what it does is it starts to contract these muscles before you even strike the ground for that next step. So what your nervous system is it's one step ahead of each of your movements. So now you are no longer reacting to a stimulus. You are one step ahead of that stimulus. So we want to think about the important role that pre-activation has in our athletes and in our patients as it deals with dynamic ankle stability, right? So if we want to do pre-activation training, we know that we need to get that information into your nervous system the fastest way possible. And this is where we're going to look at our small nerves and challenge the idea of small nerve versus large nerve training. Okay, so we have both small nerves and large nerves. Our large nerves are actually found in your muscle tendon junction. It's found in your ligaments. It's found in your capsules, while your small nerves are found in the skin on the bottom of the foot, right? So we see that small nerves, bottom of the foot, they're actually a little bit more sensitive. The response time of your small nerves is actually faster than your large nerves. Your large nerves is what you are training when you do neuromuscular training. When you're training your perineal reaction time, you are training a large nerve response. Okay? When you go onto a wobble board, a Bosu, an Eric's pad, etc., you're in a shoe. What you are training and what you are reliant on is your large nerve response. This is as opposed to training the small nerves on the bottom of the foot, getting your athletes and your clients and your patients barefoot and stimulating the thousands of receptors in the bottom of the foot. Now, how does this relate to functional ankle instability? You have an athlete, they have a history of an ankle sprain. They keep getting this giving way sensation, right? We need to do some sort of rehab. 2012 study showed that those with functional ankle instability, right? So 6 months out after an ankle injury, they have a delay in the small nerve response. What that means is that you have an athlete or a patient with functional ankle instability, you probably should be doing some small nerve training, which means let's take off the shoes, right? Let's train these specific ones here. If we look, we see that they actually match certain receptors. Skin stretch is a small nerve response that is impaired after functional ankle instability. Texture perception is another one that is impaired after functional ankle instability. So can you start to integrate skin stretch a little bit more? Can you integrate a little bit of texture and then start to stimulate those small nerves again so that we can control or prevent that functional ankle instability? Okay, so now we want to look at response time. Everything that I teach or I bring into my programming and I work with my patients, I like to have it be evidence-based. So I know that we're actually applying studies or evidence-based practices. So small nerve response time. Here's a great study that looked at the benefit or looked at the detection time between small nerves and large nerves. So what it did is they put the subjects in their sneakers and then they compared their response time to inversion moments when they were barefoot. And they saw that they had a faster response time, or they were able to detect inversion moments faster when they were barefoot, right? When we're in shoes, that's a large nerve response. When you're barefoot, that is a small nerve response. So that would mean, right, your small nerves are a little bit faster. So what they did then is said, okay, maybe we can get some sort of small nerve stimulation in the sneakered environment. So they put textured insoles into the sneakers that typically were strengthening the large nerves. And what they saw is the same response time to when those subjects were barefoot. Texture happens to be one of our small nerve responses. So whether you're barefoot or you try to stimulate the small nerves through an environment that happens to be a little bit creative, like a textured insole, you are getting a faster response, which means better stability and decreased risk of re-injury. So something to support the benefit of getting those small nerves stimulated. Okay, here in red, if you can see, hopefully you can differentiate the black and the reddish color, is the ones that are red are the small nerves. So again, skin stretch, texture, vibrations, any of those power plates that we're standing on, those are stimulating the small nerves. If you do some of your rehab or your drills on AstroTurf, right, or a hard carpet that you feel the different textures, right, you're stimulating small nerves, which is great. If you can integrate skin stretch, a lot of the footwear, and Nike has these great new hyperfills that are out. They actually have an insole that integrates skin stretch, which is very creative, and it actually gives, hence the name hyperfill, much more proprioceptive feedback through the bottom of your foot. We have to remember that your gateway into your nervous system is through the bottom of the foot. That is your contact point between the body and the ground. So let's integrate it as much as we can. Okay, so anyone who is a big Kinesio tape fan, I do a lot of Kinesio taping or kinesiology taping if you're particular to different brands, right? So the difference, if we're looking to stimulate the small nerve that is specific to skin stretch, can you use your kinesiology taping? Or should you be using your classic kind of old school elastic tape or McConnell tapes, right? What these studies have shown is that the kinesiology taping does not stimulate the small nerves like the non-elastic tape does. So what we need to do is be very specific on which type of tape you're using for which purpose. Kinesio tape works through proprioceptive response, but it's through the fascia. It's through the superficial fascia. It's not through the skin. And that's a clear differentiation between the two. Here's three different studies, actually three different studies looking at the kinesio tape, and that there was no benefit to ankle stability when you tape the ankle. Do you get a little bit faster reaction time? Yes, but it's not through the skin stretch, which is the small nerve. It's through the superficial fascia, which is a different type of proprioceptor. So again, a little bit different way. We want to understand and make sure that we're doing each of the specific programming following that evidence-based. Okay, so small nerve, get that skin stretch, try to use that white elastic tape or non-elastic tape. So if we look at vibration, right? You have a vibration plate in your office or in the gym, maybe it's a power plate, right? What this has shown is that you stimulate the ankle stabilizers through this proprioceptive stimulation. Small nerve vibration, awesome way to start waking up the bottom of the foot and start getting this proprioceptive response. Start increasing or decreasing the threshold at which these intrinsic muscles will fire. If you do vibration training, right, a lot of the research tries to keep it down below 60 seconds. So you're trying to not dull these mechanoreceptors, you're trying to stimulate and then switch to the other side. I try to get patients doing vibration platform, doing short foot, and standing on one leg. So hold that contraction of short foot, which is getting that abductor hallucis, get the vibration stimulation, do it on one leg to start getting that hip to fire, and then switch to the other side. Okay? So kind of challenge some of what we're currently doing, right? Can we start to get the pre-activation system? Can we start to get those small nerves stimulated, right? And then we'll go in a little bit more about co-activation patterns. But important question that we want to ask ourselves is, do the benefits of doing this small nerve training transfer to when that athlete puts their shoes on, right? You may wonder, okay, if I train barefoot, yes, I'm strengthening the foot. Yes, I'm stimulating the small nerves, but I'm an athlete that has to wear shoes. How can this benefit me, right? Does it really even transfer, right? And we see that it actually does. And when I start talking about the hip, that's where we're going to see our greatest benefit. Okay, so even our shod athletes should be training barefoot, and it has to do specifically with their inversion eversion strength ratios. And I'm going to bring that up a little bit more, but you want to get your barefoot eversion inversion strength ratio to match what your strength ratio is when you're in your shoes. So you want to be strong in all environments. You want to match your athlete's strength when they're barefoot to be as exact precise or exact controlled as when they put their shoes on. When you have a discrepancy between their barefoot strength and their shod strength, that's when you're seeing a high injury risk. So something to think about. Last thing that we're going to talk about as far as challenging our programming, right? And I think a lot of us probably already do this, but I just wanted to mention it, is that we're training the co-activation patterns between the foot and the hip, right? We can never address the foot without thinking about the hip. It's critical. It's innate in how the human body moves. The human body is designed to respond to plantar stimulation. That plantar stimulation goes into the hip, the deep hip stabilizers, which then goes right back down to the foot and stabilizes that lateral ankle. This work was presented by Dr. Janda, and then Friel showed a lot of glute med weakness in those patients with lateral ankle instability. So we know that there's this association between glute med weakness and ankle instability or history of ankle sprain, right? Which one happened first, right? Was it the glute med weakness that happened and that led to the ankle instability, or did the ankle instability lead to the glute med weakness, right? Some studies you still don't really know, but you could pre-screen your athletes and get those glute meds firing a little bit faster through the bottom of the foot. But remember, we need to train the foot and the hip to fire together. Short foot, always talking about short foot. If you're not familiar with short foot, definitely check it out. Again, presented by Dr. Janda and a lot of his research. This exercise specifically strengthens the intrinsic muscles in the foot. And what it does is it gets a co-activation into your deep six stabilizers of your hip, which then goes into your pelvic floor, which means now your glutes can fire a little bit faster and stronger. So, teaching our athletes to initiate movement from the ground up, not only is that going to stabilize that foot, but it's going to stabilize that hip so much faster. The more stable that their hip is, the more stable that lateral ankle is going to be, and the decreased risk of injury or re-injury that athlete is going to experience. So, strong believer in training foot and hip to work together and to fire faster. So, we're going to talk real quick about prevention and ways that we could maybe pre-screen injury risk in our young athletes before they even get their first ankle injury, right? So some things that we can actually pre-screen our athletes for. First one is what's called delayed perineal reaction time. And I know it's a large nerve response, right? But having a delayed perineal reaction time, it really is still the foundation of ankle rehab. We know that we need to integrate some small nerve, right? Proprioceptive training. But if you can screen your athletes for a little bit delayed reaction time, you may be able to say their large nerve response time is a little bit delayed, so I need to get after their small nerves so that they will be faster, more stable, and never experience that first ankle injury, right? An approach that we could do. This perineal reaction time is tested through an NCV. So certain athletic clubs, or if they have insurance, you can pre-screen, right? We have an NCV in our office. You can actually pre-screen and start to detect some of these reaction times in that perineal nerve. What we can do is also pre-screen for the eversion to inversion strength ratio. Remember that it's not just eversion to inversion strength ratio in their shoes, but you want to compare it to their strength ratio when they're barefoot. If you see a difference in how stable or strong an athlete is when they're barefoot compared to when they are in their shoes, that puts them at a high injury risk, and that could be something that you could pre-screen. That means that that athlete specifically needs to work a little bit more on bringing those two environments closer. And that's where you really could use some of that minimal footwear. Train barefoot, train minimal, and then get into whatever shoes that athlete has to actually compete in, whether it's a basketball shoe or a cleat, right? Again, the new Hyperfill, I'm just so excited by this Hyperfill because it stimulates the bottom of the foot in this whole new way. It's a great way to bridge that gap between barefoot and that shod environment that that athlete has to play in, right? Let's bridge that gap with some sort of footwear and then train in all three environments. Do your dynamic training, do your balance training barefoot in the minimal shoes and then in whatever shoes they actually train in. Okay, that study was shown by Yenties. Great study. Last one that we can pre-screen our athletes for is glute med weakness, right? We know that we need a stable hip. Can we do a little bit of pre-screening for glute med weakness, right? And then get those athletes early. We need to be catching these athletes before they get their first ankle injury. So we can start looking at their large nerve response to perineal reaction time. We can start to look at their stability in different environments. And if there's a discrepancy, know that they're at high risk. And then we can pre-screen them for that glute med weakness. Again, eversion to inversion strength, it's not just the ratio, it's more about the variance in that ratio between the different environments. Okay? Fatigue is the last thing that I'm going to talk about, the role of fatigue. When we are fatigued, and if you look at injuries, especially ankle injuries, right, a majority of these injuries are happening in that second half of the game, right, or the last 5 minutes of that game, where we know that these athletes are getting tired, they're fatigued. What happens is that you get ligament laxity when you are fatigued. And ligaments, if you're relying on your ligaments to provide you proprioceptive feedback, that's not good. Your ligaments have what's called a dead zone, right? You do not get a stimulation from your ligaments until they are at their end range of motion or their full stretch. So if you now have an athlete who is fatigued and they're starting to get ligament laxity, their dead zone is becoming greater, right? So they're not getting that proprioceptive response through that ligament until it's probably way too late and they're into too much inversion to ever protect that ankle, right? So we either, as coaches, want to pull these athletes out a little bit early, look for the signs of fatigue and really appreciate the role that fatigue has in ankle injuries and delayed proprioceptive response, or integrate programming that specifically offsets fatigue, right? Can you delay the fatigue of the glutes and that hip stabilizer so that your lateral ankle maintains its stability, right? It's another way to look at the role of fatigue. Either pull those athletes out or try and delay that fatigue through maybe your small nerve pre-activation training. That's a way to do it. Maybe integrate some of that short foot when you know that the athlete is getting tired, and let's kind of kick those hips back into gear and get them firing again. Some ideas to kind of throw out there. So, in summary, right, some things that we can do to spice up our programming and maybe get a little bit better results is understanding and appreciating that 70% of ankle sprains are experiencing recurrent symptoms. After one ankle sprain, you have the 5 times increased risk of re-injury, right? Our treatment and more effective treatment should focus on integrating pre-activation training. Your pre-activation training is done through small nerve proprioceptive training, which is through the bottom of the foot. So let's get these athletes and patients barefoot. We also want to train the co-activation patterns between the foot and the hip, knowing that that gateway is through short foot or through the intrinsic muscles. Get that foot to start responding and get that signal to get into the hip a little bit faster. And then finally, if we think about prevention, if we don't want these athletes to ever get even their first ankle sprain, right, what we need to do is decrease that discrepancy between their strength in different environments. Get them training barefoot, minimal, in their training shoes or cleats or basketball shoes, and try to get those environments as close to each other as possible. And then look at the role that fatigue has in ligament laxity and delayed proprioceptive response. And either integrate programming to offset fatigue. Again, barefoot science is a great way to offset fatigue, or let's pull these athletes a little bit sooner so that they are not getting fatigue-related ankle injuries. Okay, a lot of this, I hope that it was somewhat stimulating and maybe challenged or gave you a few fresh or creative ideas of things that you can sneak into your programming. If you already do barefoot rehab with your patients and your athletes, that's awesome. Awesome. I'm all about getting that small nerve stimulation. Are you integrating short foot into your exercises? If you haven't yet, but you have them barefoot, maybe that would be one way to kind of take it a little step further and really get that hip firing with the foot. This research, in addition to other research related to this, is built in the programming of EBFA's newest program, which is our Barefoot RX, or our Barefoot Rehab Specialist. And what it is it's built around barefoot science for rehab programming. So whether it's in the hip, the lower back, the knee, the foot, barefoot science as a form of neuromuscular training has a role in a rehab setting. So it's really exploring some of those really cool benefits of how to train the body for functional movement or rehab from the ground up. And again, that's really the take-home message through EBFA in our programming. So if anyone has any questions, they can definitely type it in. Questions on my experience or maybe some things that you saw or you integrated, and then we can go through that. All right, so is there a difference between somebody rehabbing barefoot versus wearing a sock? And that's a very good question. I actually get that a lot. And you have to think about that. Once you put a sock on, you're blocking the small nerves. So yes, you feel the ground, right? So if you stepped on a pebble or something like that, you would be able to have the tactile differentiation to feel that, but your small nerves are very sensitive, right? We're talking about light touch and texture, that we want to get that foot totally open and exposed to the surface and the stimulation. So being completely barefoot, 100% better. If they will not, um, there's different kind of modalities that you can get them in. Again, Nike has, not to keep plugging Nike, but Nike has a studio shoe that integrates some sort of small nerve stimulation within it. So maybe there's a little bit sneakier ways that we can do this. Maybe that patient or that client would be more appropriate to use like a textured sole. So you're getting the small nerve stimulation versus kind of fighting with them. They don't want to take off their sock. They want to stay in the sock. You want to get the small nerve stimulation. So it's another way to look at it. How do you often assess the ratio between eversion and inversion, either barefoot or shod? I'll do a balance test. And I know you can't, it's hard to do like an actual eversion, like a resisted eversion or inversion strength ratio. But I will do all of my balance tests, and I'll do the balance tests barefoot and then compare them to a minimal environment. I do a lot of dynamic drills on one leg. You can do a Y test, you can do a star excursion, whatever different modalities that you use. If they're doing lateral movements, if they're doing a jump, if they're doing a step down, you just want to see what their dynamic ankle stability is compared in a barefoot environment to a minimal or a shot environment. And you can even go through subjective as well, right? Does that athlete or patient feel just as stable and grounded in their minimal shoe or in their sneaker or their cleat compared to when they're barefoot? And if they say yes, if they say no, right, that also gives you some perspective. But I will do actual balance testing and dynamic ankle stability testing barefoot, minimal, shod, and then comparing. And you want them to all be as similar as possible. So question, do you know in the textured insole study, were the subjects wearing socks or was it a textured insole against the skin? It's my guess that it was the skin against the textured insole. The thing with, but I'll go back 100%, Jennifer, and I'll let you know, is the texture. If you're thinking about texture and the creativity of using texture, is it actually has to be close enough. So it has to be micrometer distances from each other to actually stimulate the textured response. So it's not as grandiose as maybe you're thinking. Think micro texture and stimulation, and that's what's going to get that small nerve response. And then as far as the inversion, eversion, second part of your question, I think that I answered that as well. So as far as vibration training, great question. Should it be done barefoot or in a shoe? I always do it 100% barefoot because, again, you want to get the small nerves stimulated. Remember that your goal through small nerve training is to get the most skin surface contact. So if you put a sock between the skin and the surface, you're increasing that barrier between skin surface contact. So doing that, AstroTurf and things like that, that's why it's also good, because you want as much skin surface contact. And then finally doing the vibration platform, you want that to be barefoot as well, because you want skin surface contact. And these small micro vibrations get into every material that's between the foot and the ground. So you want the skin and the receptors to be taking in all of those vibration stimulation. Okay, never mind. There was a question on that was canceled. Any evidence with the loss of dorsiflexion and diminished proprioception? That's a very good question. I don't know, Scott, but I'm going to look at that as far as like dysfunctional movement patterns. I do know that after an ankle sprain, a lot of these patients or these athletes get a shift, an anterior shift in their talus, which can create a bony block and a loss of dorsiflexion, which then you now have this impaired ankle stability because they're not moving through the full range of motion. So that's maybe like a back-ended way of saying, yes, they have diminished proprioception, but I don't know if it's directly related to an actual alteration in the proprioceptors. But I do know ankle instability, they get an anterior shift in the talus, which limits their dorsiflexion, and then they typically have poor ankle stability. Um, any other questions? You guys have great questions. Great questions. All right, how about zero shoes? Zero shoes, if anyone's unfamiliar with zero shoes, this is like a Hirachi sandal. Um, the foot is free, yes, which is what we like, but it is something between the ground and the foot. And what we're talking about between small nerve stimulation and like ankle rehab, right? We want to do this in different environments. So do your first like 5 minutes or 10 minutes of your programming or your rehab completely barefoot. And then if you're doing other movement and you want to put on your zero shoes or you want to put on any other minimalist type shoe, 100% do it. But you have to first open up your gateways, open up all of these nerve channels, and then get the foot responding and the hip responding and get into these different environments. Okay, so I would start out with completely barefoot. And then if you want to put on the zero shoe or your patient or athlete wants to put on a zero shoe, 100%. You still have the freedom, yes, but you want to kind of open up that nervous gateway. Okay. Far as the hurts, what I typically do is you want it to be a low velocity and a lower frequency for the vibration. I can send you the exact hertz that I use. A lot of them actually have settings that you can alter them, or they're pre-programmed settings, and they actually have waves, or the vibration platform either goes more like a vertical versus a shift. So there are different types of vibration patterns that you're doing. The ones that you want to do are not the vertical, but they're more like the sinusoidal vibration patterns. That's what you want. That's a little bit more. Think lower velocity, so you don't want to be cranked up as high as you can. 60 seconds per side, and try to get complete barefoot, doing short foot, and doing a single leg at the same time. If you do isometric contractions with your short foot, you can do on a vibration 10 seconds, right? 10 seconds short foot, get the isometric contraction, get the stimulation, release it, do another contraction, 10 seconds, short foot, engage it, hold it, vibration platform, release it. Do that 5 times and then switch to the other leg or something like that. And then I would move on, get off of the platform and start doing other stimulation. Go on to something that's textured, or start doing different kind of single leg exercises to get the foot and the hip to move together. Something that you would integrate creatively that way as well. Short foot feels really odd, and I feel it in the knee sometimes. Is this normal? The short foot you should feel in your hip, and you're not going to feel your hip in the sense like if you put your hands on your glutes, you're not going to feel your glutes contract. It's actually much deeper than that, right? We know it's your deep six muscles that are firing. When you do short foot, you should feel again something deeper. Some people will feel their hamstrings and their quads, etc., depending on how you do the exercise. But do not grip your toes. So I would focus on just the hallux or the big toe. So when you do a short foot, just think about pushing the big toe down into the ground. Don't think about curling the foot in. Don't think about pulling the metatarsal heads towards the heel. This starts to confuse patients and clients. Just think about the hallux. Push the hallux straight down into the ground, and you'll actually see the abductor hallucis contract. If you focus on pulling the foot into making it literally a short foot, then you start to pull the toes in and you kind of contract in. Totally different move. The end result is the same. I find, just from my experience of explaining it to so many people, is that if you focus on pushing the hallux down or the big toe down, you get your contraction and you're good. Don't give them the cue of pulling the met heads in, because then they're going to start contracting the digits. And then see if it works. You can actually feel the bottom of your foot. You can put your hand on the arch and feel the muscle contract and engage. Question on, should the athlete use a textured insole only in training sessions, or should it be used when returning to competition? You would want to train it both ways and then see how it responds. You wouldn't want to throw something new into the athlete's environment if they haven't trained in it, because that same transfer, their first time in a textured insole, especially from like a game standpoint or a competition, may not be the best idea. Right, so training it. But if you do feel that they get faster response time, then having that textured insole in their cleat or in their basketball shoe makes sense. It would be an advantage, right? So something to think about. And then do you cover my exam? Do I cover my exam in the Barefoot Rehab Specialist course? I assume that you mean my inversion, eversion exam and my barefoot minimal shod balance test exam. Yes, I do. Huge proponent. A lot of patients that I see have this ankle instability, and all of them are rehabbing with this barefoot science and from the ground up approach and co-activation patterns, small nerve stimulation, and reaction time. And thankfully, I've been having very good results, and I'm getting these athletes back into their sport that they're playing. I get some parkour, I get, Muay Thai fighters and, different athletes that have to have quick reaction time and have serious injuries like full thickness tears, and they're back into their sport. So, yes, I definitely do cover that. You are welcome to the rest of everybody's comments and questions. So, again, thank you all for tuning in. If you stuck around to hear the questions, very special thank you. If you're curious to learn more about our Barefoot Rehab Specialist Program or Barefoot RX, please check it out. We're updating everything on the EBFA website. The next training that we're having in New York City is December 7th, and it's in conjunction with Triarch, which we're a big fan of the Triarch family. And then we have another one in February 2014, and then January 2014 as well. So already looking at 2014, which is scary. So again, thank you everybody. Have an amazing night. Have a great weekend, and stay tuned for our November webinar, which is going to be on yoga science. So we have Dr. Kibbert, who's going to be joining us as our guest educator, and it again is going to be on yoga science. So a creative way to integrate yoga into movement. All right. Thank you guys so much. Take care.